By Dr. Piyush Bansal. It's surgical pearls for macular hole surgery.
याद तो नहीं मुझे लगा याद नहीं मुझे लगा Good afternoon, everyone. So I'll just be quickly showing some case scenarios and hopefully some pearls for macular hole surgery. As we all know, the primary management for macular hole treatment is essentially a vitrectomy with ILM peeling with internal tamponade. Tamponade may change depending on how big the hole is, or perhaps not even a tamponade. So this is incidentally the first macular hole surgery that I had done maybe a decade ago. As you can see that the technique is comparatively old, it's an older video where I'm going across the macula with the ILM peeling after the vitrectomy, of course. And by and large, we've stopped using that technique now. What we do is just similar to cataract surgeons, wherein they do a capsular excess. We can do a peel all around the macula. As you can see, it's being done with an ILM forceps over here, and then try to extend the peel as much as possible easily. Of course, it's not mandatory to go from arcade to arcade. What is important is having a good area of clearance around the macula, maybe around 300 microns or so. Again, this technique can be used for smaller holes, but for larger holes, we've pretty much shifted to inverted flaps, wherein we leave some amount of the ILM attached to the whole edge. As you can see over here, the peeling has been initiated superiorly, and then it's going on inferiorly, and then again start again superiorly on the other in the other circumference. So this essentially is a 180 degrees type of peel, but you can also do a cauliflower kind of peel, wherein you have multiple leaflets. So again, you see there's a residual ILM flap that is kept over the macular hole. It's never to be stuffed inside. We don't want to damage the RP. We don't want to unnecessarily cause reduction in visual potential. So following that, you can extend the area of the peel as much as possible. In a traumatic macular hole, the peeling can be comparatively easier because the ILM is slightly loose over here. As you can see, it's a punched down kind of a hole. However, in these kind of cases, it's important to make sure that you have a good PVD induction, because PVD induction in these patients is comparatively more difficult as compared to routine. And again, I don't use diamond dusted forceps, or I don't use finesse loops that often. Finesse loops sometimes in difficult cases, especially when it's it's a longer eyeball. Otherwise, I prefer using the ILM forceps, as you can see over here, and then gradually pinching and peeling, not being too aggressive, and then making sure that you don't lose your flap over here, because in traumatic cases, you can always end up with surprises. So it's a large hole, of course, so you require a larger, a definite inverted flap, and I like to trim the flaps. I don't like to have too much of ILM over there, because what happens is during fluid air exchange, the chances of the flap moving out of place is higher. Now, this is a macular hole with a retinal detachment, of course, with a separate retinal break. So you treat it as a macular hole and a retinal detachment case, and after doing a vitrectomy, what is being done over here is base shaving, and then making sure that all the vitreous near the retinal break is removed. It's very important to remove all vitreous, just like a routine retinal detachment. It's important to remove the vitreous attached close to the break, and making sure that there's no residual traction, otherwise you'll end up with a recurrent retinal detachment. And after this is done, the focus is moved to the macular hole. As you can see, it's despite doing fluid air exchange, the retina was still it's embolus. So in that situation, I preferred using a PFCL bubble. You can use a larger PFCL bubble also to flatten the retina and then peel the ILM underneath the PFCL bubble. And what I am using it essentially is to give some amount of counter traction. Now you can see that there's a nice area of ILM peel around the macular hole, and then the attention is taken back to the break, do a fluid air exchange, and make sure that the retina is on. After this is done, the next step would be, of course, to do endolaser all around the break. Now, I don't prefer to do a 360 degrees laser. I especially making sure that if one is of course not sure of other lattices, other areas of breaks, then you can do a 360 degrees laser. Otherwise, target it only around the retinal breaks. And of course, these cases require silicone oil. You can't get away with gas in these kind of cases. Now, what I've done is I've moved away from using PFCL and just macular hole RDs. As you can see over here, there's no PFCL, and the ILM peeling is being done in a detached retina. And it's not that difficult with patients and a slight more experience. One can do it. It's a large hole that you see over here. So the plan is to have a inverted flap over here. So the chances of hole closure are higher. Now, what is important is again not to stuff it. And second important point is never to drain fluid from the macular hole. Create a separate retinotomy and then drain the subretinal fluid, as you can see being done over here, following which do a fluid air exchange. Now, this is a video by my senior colleague, Dr. Rupakanti Biswas from Kolkata, wherein in a failed macular hole, what he does is, if there's no ILM that he can really see, he takes a retinal autograft using a trephine. In this case, it was a 550 microns trephine. And then lifting up the refined retina and then making sure that the orientation of the piece is maintained, and then under air placing it at the macular hole. Now, visual prognosis in these kind of cases is of course not as good as your primary macular hole surgeries, but yes, you can achieve anatomical closure, and some amount of visual improvement can be expected, but again, it's following which you do a fluid air exchange. Thank you very much.
Thank you, sir, for this very nice demonstration. I have two questions for you. Sir, do you have any experience with AR only?
Can you repeat, ma'am? Sorry.
Do you have experience with AR only tamponade?
Yes. Yes. For smaller holes, patients who are diligent with their, of course, I don't have intraoperative OCT. Otherwise, what I would like to do is check it over there and then maybe keep the patient for some time. We discharge our patients anyways. Most of the hole closures in the smaller ones is generally achieved in a day. So if you can call those patients again and see, you can even stop your positioning. And depending on your surgery, I mean your experience, you can definitely use just air for tamponade. We've reduced the concentration, the amount of SF6 or C3F8 that we use also. So air is definitely being used. But for larger holes, I still prefer expansile gases.
Second is, you must have some series of cases with this autologous transplant. Visual outcome, how much it is
so I have no
significant from not doing surgery or non-closure, then transplant?
Yes, so I have zero experience with autologous transplant. That is my senior colleague's case, but he has quite a few patients now that he has done, and his visual prognosis is again, some patients did improve to the tune of 660 or 200, but not every patient improves. The chances of the prognosis is better, like I said, with primary macular holes.
In inverted flap, you prefer a single flap closure or
I prefer signal. There are multiple techniques out there. In fact, the most recent one is people are doing a temporal flap and just peeling temporally. Some people use multiple flaps placed over each other. Again, I don't see the need for all of that, but temporal flap, yes, but not multiple flaps.
But if resurgery is required, you prefer from which area you usually take other initial flap dislocated?
Again, a free flap is also being done. The free flap is generally taken from the nasal retina. Again, I have not done free flaps too many times, just a few cases. We've achieved hole closure in, I think, in 4 out of 5. The 5th one, I think, was lost to follow-up. So again, there are multiple techniques.
Thank you once again for this nice presentation and nice
Thank you.